Parasomnias represent some of the most fascinating and sometimes disturbing phenomena in sleep medicine, a diverse group of sleep disorders characterized by abnormal behaviors, movements, emotions, perceptions, and dreams that occur while falling asleep, during sleep, or during arousal from sleep. Unlike insomnia, which involves difficulty initiating or maintaining sleep, parasomnias involve inappropriate activation of physiological systems during sleep-wake transitions or partial arousals. The sleeping brain essentially becomes caught between sleep states or between sleeping and waking, triggering behaviors that would normally be suppressed during consolidated sleep. These episodes can range from the relatively benign, such as sleep talking, to the potentially dangerous, like sleepwalking into hazardous situations, all occurring while the individual remains partially or completely unaware of their actions. The classification of parasomnias follows their relationship to specific sleep stages, providing important clues about underlying mechanisms and appropriate treatments. Non-REM parasomnias occur during the deeper stages of sleep, primarily slow-wave sleep, and include disorders like sleepwalking, somnambulism, sleep terrors, and confusional arousals. These disorders share characteristics of partial arousal, where the brain partially wakes from deep sleep while remaining partially asleep, creating a dissociated state where complex behaviors can occur without conscious awareness. REM-related parasomnias, by contrast, occur during dream sleep and include REM sleep behavior disorder, nightmare disorder, and sleep paralysis. These conditions involve disruption of the normal muscle atonia that typically accompanies REM sleep, allowing dream enactment, or in the case of sleep paralysis, persistence of muscle paralysis into wakefulness. Other parasomnias occur during sleep-wake transitions or across multiple sleep stages, including sleep-related eating disorder and sleep-related hallucinations. Sleepwalking represents one of the most widely recognized parasomnias, affecting approximately 4% of adults and up to 15% of children. During episodes, individuals arise from slow-wave sleep and engage in behaviors ranging from simple ambulation to complex activities like preparing food, rearranging furniture, or even driving vehicles, all while remaining functionally asleep. The sleepwalker's eyes are typically open with a vacant expression, and they may respond to others in a confused manner or not at all. Though popular culture often portrays sleepwalkers as zombie-like figures with outstretched arms, the reality involves normal movement patterns executed without conscious awareness. Episodes typically last from several minutes to half an hour, with no memory of the event upon awakening. While many cases resolve spontaneously in adolescence, adults with persistent sleepwalking may require intervention, particularly when episodes involve potentially dangerous behaviors. Sleep terrors present as perhaps the most dramatic parasomnia, with episodes beginning with a blood-curdling scream followed by intense behavioral manifestations of extreme fear. The affected individual appears terrified, sitting upright in bed, breathing rapidly, sweating profusely, with dilated pupils and racing heart rate, yet remains unresponsive to comforting efforts from others. Unlike nightmares, which occur during REM sleep and are typically remembered, sleep terrors emerge from slow-wave sleep and leave no memory trace. Parents often find these episodes more traumatic than the children experiencing them, as the child typically returns to peaceful sleep while family members remain shaken by the intensity of the apparent distress. Like sleepwalking, sleep terrors occur more frequently in children and often resolve spontaneously with age, though they can persist into adulthood or emerge for the first time in adults experiencing certain triggering factors. REM Sleep Behavior Disorder, RBD, represents a particularly concerning parasomnia with significant clinical implications. This condition involves loss of the normal muscle paralysis that typically occurs during REM sleep, allowing individuals to physically act out their dreams. Episodes often involve violent movements matching aggressive dream content, punching, kicking, jumping from bed, potentially injuring themselves or sleep partners. Unlike non-REM parasomnias, RBD predominantly affects older adults, particularly men, and patients can typically recall dreams corresponding to their behaviors. Beyond its immediate consequences, RBD often serves as an early warning sign for neurodegenerative disorders, particularly Parkinson's disease and related synucleinopathies. Research indicates that a substantial majority of individuals with idiopathic RBD eventually develop these neurological conditions, making this parasomnia an important marker for early intervention strategies and longitudinal neurological monitoring. Sleep-related eating disorder involves recurrent episodes of involuntary eating and drinking during partial arousals from sleep, with subsequent amnesia for these events. Affected individuals discover evidence of nighttime eating, food missing from the kitchen, dirty dishes, food wrappers in bed, without any recollection of consuming these items. Unlike nighttime eating syndrome, which involves full consciousness during eating episodes, this parasomnia occurs during a dissociated state of partial sleep. The condition carries significant health implications, including weight gain, potential ingestion of toxic or inedible substances, and preparation of food with impaired judgment that creates fire or injury risks. Many cases emerge secondary to other factors such as medications, particularly sedative hypnotics and certain psychiatric medications, other sleep disorders, or eating disorders, making thorough evaluation essential for effective management. Sleep paralysis creates one of the most terrifying subjective experiences among parasomnias, often serving as the foundation for supernatural beliefs across cultures. Episodes involve temporary inability to move or speak while falling asleep or upon awakening, essentially experiencing the muscle atonia of REM sleep while conscious. This disconnection between consciousness and motor control frequently generates intense fear, particularly when accompanied by hallucinations consistent with dream imagery intruding into wakefulness. These perceptual experiences often include sensing an ominous presence in the room, pressure on the chest, or sensations of floating or being touched. While isolated sleep paralysis episodes are relatively common in the general population, recurrent episodes causing significant distress may constitute sleep paralysis disorder requiring clinical intervention. Cultural interpretations of these experiences vary widely, from the old hag of Newfoundland to the ghost oppression of Chinese culture, reflecting the universality of this neurophysiological phenomenon. Nightmares and nightmare disorder represent the emotional counterpart to pleasant dreams, occurring during REM sleep and involving dysphoric dream sequences that typically result in awakening. While occasional nightmares are universal experiences, nightmare disorder involves recurrent, extremely dysphoric, and well-remembered dreams that cause significant distress or impairment. The content typically involves threats to survival, security, or physical integrity, though themes vary with age and individual circumstances. Nightmares differ from sleep terrors in several key aspects. They occur during REM rather than slow-wave sleep. People can recall their content in detail, and they do not involve the dramatic autonomic activation characteristic of sleep terrors. Clinically significant nightmares often emerge in the context of traumatic experiences, anxiety disorders, or substance use, though idiopathic cases also occur. Treatment approaches include medication adjustments, image rehearsal therapy, mentally rewriting nightmare content while awake, and addressing underlying psychiatric conditions. The etiology of parasomnias involves complex interactions between genetic predisposition, developmental factors, and environmental triggers. Family studies consistently demonstrate heightened prevalence of non-REM parasomnias among relatives of affected individuals, suggesting genetic components. Developmental factors play substantial roles, particularly for childhood parasomnias, which often reflect immature sleep system regulation that resolves with neurological maturation. Environmental factors serve as crucial triggers, with sleep deprivation representing perhaps the most powerful precipitant across many parasomnia types. Additional triggers include fever, stress, alcohol consumption, certain medications, and underlying medical conditions. Many parasomnias exhibit priming effects, where the threshold for episodes lowers following periods of sleep deprivation or stress, highlighting the importance of sleep hygiene and stress management in prevention strategies. The diagnostic evaluation of parasomnias requires comprehensive assessment beyond simply identifying the abnormal sleep behaviors. Detailed clinical interviews explore the timing, frequency, and characteristics of episodes, often incorporating information from bed partners who witness events the patient cannot recall. Sleep diaries track patterns that may reveal relationships between episodes and potential triggers. While most parasomnias can be diagnosed clinically, polysomnography, overnight sleep studies, provides valuable information in complex cases, allowing differentiation between parasomnias and conditions with similar presentations, such as nocturnal seizures. Video polysomnography proves particularly useful for capturing actual episodes, providing objective documentation of behaviors and corresponding sleep stages. Home video recording sometimes serves as an accessible alternative when formal sleep studies are unavailable or impractical. Management approaches for parasomnias emphasize safety measures, trigger avoidance, and targeted treatments for specific conditions. Safety interventions include securing the sleep environment by removing hazardous objects, installing bedroom door alarms, securing windows, and sleeping on mattresses placed directly on the floor to prevent fall injuries. Scheduled awakenings, systematically waking individuals approximately 15 to 30 minutes before typical episode timing, effectively reduces episodes in some cases, particularly for children. Cognitive behavioral approaches benefit certain parasomnias, especially imagery rehearsal therapy for nightmares and relaxation techniques for stress-triggered episodes. Pharmacologic interventions vary by parasomnia type, with clonazepam showing particular efficacy for REM sleep behavior disorder, while non-REM parasomnias may respond to low-dose benzodiazepines or certain antidepressants. Optimizing treatment of underlying conditions often reduces parasomnia symptoms, particularly when episodes are triggered by sleep apnea, mood disorders, or medication effects. The impact of parasomnias extends beyond the affected individual to family members, sleep partners, and sometimes entire households. Parents of children with parasomnias often experience significant sleep disruption and anxiety about their child's safety. Sleep partners of adults with REM sleep behavior disorder may sustain injuries from dream enactment behaviors or develop their own sleep problems from hypervigilance. Social embarrassment and relationship difficulties can emerge from certain parasomnias, particularly those involving unusual behaviors or vocalizations that others might find disturbing or difficult to understand. Support groups provide valuable resources for affected individuals and families, offering practical management strategies and normalizing experiences that can otherwise feel isolating. Addressing these broader impacts remains an essential component of comprehensive parasomnia management, recognizing that effective treatment benefits not just the patient, but their entire social system. Recent scientific advances have deepened our understanding of the neurobiological underpinnings of parasomnias while expanding treatment options. Neuroimaging studies reveal selective activation of motor regions during REM sleep behavior disorder, explaining the dissociation between continued dream imagery and loss of normal muscle atonia. Investigation into the genetics of parasomnias has identified several candidate genes potentially involved in sleep state regulation and transitions. New medications targeting specific neurotransmitter systems show promise for parasomnia management with fewer side effects than traditional agents. Increased recognition of the relationship between certain parasomnias and neurodegenerative processes has spurred research into neuroprotective strategies that might delay or prevent disease progression. These scientific developments, combined with growing public awareness and destigmatization of sleep disorders, offer hope for improved identification and management of these fascinating but often challenging conditions.